Hi, good evening, everyone. I would be very happy to take few questions at the end of this session. So, as we are aware that in India we have challenges pertaining to the identification of branded patients, and there are a lot of laws, very stringent rules and regulations that are associated with identification of a branded patient. First, let us see the global burden. Okay, as far as the organ transplantations are concerned, uh, you know, uh, till 2013, the number of transplants, solid organ transplants, which were reported were around 1,17,000 worldwide. But there has been an increase in number of organ transplantations, and there was increase in 2.6% percentage of organ transplantation over a period of time. But that is just less than 10% need of the global number of patients globally. Okay, and then we have seen that a lot of kidney patients are dying, and a lot of liver and heart and lung patients are also dying, and we need the number of transplants are basically very minuscule in number when we compare with the need. As far as the kidney transplantations are concerned, the need is around 1,50,000, but we are able to do only 7,500 odd transplants in kidney, and for liver also, the numbers are very meager. 30,000 patients need liver transplant, but we are able to do only 1,400 liver transplants. And heart, the need is significant, but we are able to do only maybe around 100 transplants over annually. So, but for heart transplants and lung transplants, we have to be completely dependent on the cadaveric donations. And then majority of the transplant that happen in India are all based on basically live donors. The one of the family member has to do a sacrifice and donate a part of either liver or kidney or the eyes, for transplants. But the organs like lung and heart, where you have to be completely dependent on cadaver, so we will never be able to achieve if we remain dependent on families for donation. We will never be able to complete and fulfill the demands of those patients who need heart and lung. And when we see the number of transplantation that are happening, the southern side of India is contributing a lot as far as the transplantations are concerned, and branded, or we call it as cadaveric organ donations are concerned. Majority of these are happening from the southern side, and northern side is contributing very less. Okay, so as we know that one branded patient can donate many organs. Okay, so the donations can happen from dead patients who can be branded, or who may become dead after sudden cardiac or cardiac death. Okay, so in brain dead patient, you have a lot of time to prepare and prepare the recipient as well. But for cardiac death donations, the time duration is very short, and then you cannot prepare recipient and operating room and the team also. So it becomes very difficult to, get all these people, immediately prepared for transplantation. One brain dead patient can donate eyes, skin, tissues, bones, you know, liver, kidney, and then lungs and, hair, or entirely, if you wish to donate, the entire body can also be donated for teaching purposes. But no organ can be left, you know, and then practically almost all the organs of the body can be donated. And when the transplantations happen, one kidney can be donated, part of the liver, skin, and bone marrow is transplanted, and then it has to go through a authorization procedure, which may be either local or at state level committee, which decides about and help and facilitate the organ donation procedure. So, as far as world cadaver donors are concerned, Spain, Belgium, they contribute more than 30 per million per year. So these are number of cadaveric donations which are 30 per million per year. In USA, it is more than 25 cadaveric donations per million per year, and United Kingdom is almost the same. But in India, if you see, these numbers are very, very miserable. It is less than zero point 0.5 per million per year, and we have to do a lot in terms of organ donation. So that's why we need to bring awareness about organ donations, and we need to establish protocols and processes for organ donation. And Noto Soto has come up with the protocols for identification of branded patient,
Excuse me, sir.
management of branded patient. Yeah, are you able to see the screen?
Yes, sir, I'm able to see the screen. My
Okay.
concern is that, yeah, I mean, as this is an EDIC exam,
Yeah.
so is the data regarding India, is it relevant here?
Yes, yes. From this, I mean, we should have a comparison of Indian data with the Western data, and then we'll go through the main process of identification and management of branded issues. So this was in short that I would like to highlight. Okay. So as we see that number of trauma patients, who come up, who become branded, is the maximum, and then young population, young individuals are, the numbers of the organ donation that can happen are majority are from young individuals, because these individuals suffer accidents, and then they develop grievous injuries, they become brain dead. But these brain dead patients are not converted into the organ donors. Okay, and then there are a lot of laws, and there are a lot of social and other religious factors that come in between, and then that doesn't help us, to develop a robust organ donor program in an hospital, especially municipal corporation or government hospitals. You have a lot of challenges pertaining to, conversion of these brain dead patients into organ donors. But even if we have identified a patient as brain dead, so are we able to diagnose how well we diagnose these patients? And once we have diagnosed these patients as brain dead, do we efficiently maintain these brain dead patients? That is what is I'm going to emphasize more on my presentation today. So the Transplantation of Human Organ Act was established in 1994. We need to remember this. Okay. And a diseased person is a person in whom you see permanent absence of or any evidence of life in the form of either branded or in the form of cardiorespiratory sense. The patient can become patient can become, a diseased person in the form of either branded or cardiopulmonary, arrest kind of situations where the patient can become, dead. So basically, brain dead is a situation where the brain functions are not optimum, but the other organs may start, functioning on its own. Okay, the other organs may be working, on its own for some time, till the compensatory mechanisms are altered. Okay, so but in patients who have cardiorespiratory arrest, so these are the patients where there may be immediate death. But when the patient is brain dead, there may not be an immediate death. So, so when somebody is brain dead, he reach a stage in which the functions of the brain has been irreversibly ceased. Okay, and then there are no, you know, there is no chance that this patient ever become, functional or can become normal. So we need to identify what are the brain death criteria. When can we call somebody as having brain death criteria? So when we want to establish, brain death, there should be presence of irreversible coma. Okay, and there should also be absence of brainstem reflexes, and then patient should not be breathing, and also we should be able to establish the primary cause. So unless we establish a cause for brain dead patient, we can't, declare that patient as having a brain death situation. So for that, we need to, have a proper documentation, and then that is possible only by going through different processes of uh, identification of brain death. So the first step that is very important when somebody is declared as brain dead is we need to find out the underlying cause, what has led to that patient becoming brain dead. Okay, and then unless we have any cause, we cannot proceed for identification of brain dead or probably maintenance of the brain dead. Okay, so without a clear cause, we should not proceed. Okay, step two is we need to also find out the confounding factors. So when the patient is brain dead, there are other, clinical situations which may be mimic like a brain death, situation. So these factors also we need to take into account, and we need to correct these confounding factors, whether it is electrolyte imbalance or whether it is acidosis or whether it is the influence of medications, sedative agents, or and so on and so forth. We need to find out these confounding factors, establish the cause, and then we need to correct these causes. Like if the patient has electrolyte imbalance or hyponatremia, we need to correct, and then only we can proceed for brain death identification.